we did was on ventilation. And we spent a lot of time in that lecture talking about alveolar ventilation and dead space ventilation and the clinical impact of that and so forth. And this was the relationship discussed in some detail, which is that the arterial PCO2 is determined by how much carbon dioxide is being made by the tissues, and the difference between minute ventilation and dead space ventilation, which is alveolar ventilation. And we talked about how we can measure some of these things using the NICO device and so forth. And then the last time we talked about diffusion across the alveolar capillary membrane. And we said that the rate at which a gas diffuses across a membrane, in this case it would be the alveolar capillary membrane, is determined by the surface area, by the thickness of the membrane, by characteristics of the gas, the diffusibility of the gas, and the concentration difference, in this case, between the alveolus and the bloodstream. So that then brings us to the third talk, which is on pulmonary blood flow. So we talked about ventilation, diffusion across the alveolar capillary membrane. So today we're going to talk about pulmonary blood flow and what affects the flow of blood through the lungs. So our objectives are to state the normal pressures in the pulmonary circulation, to list factors that affect pulmonary vascular resistance. We'll talk a lot about that. We'll talk about how positive pressure ventilation and heat can affect pulmonary vascular resistance in both good ways and bad ways. We will compare selective and non-selective pulmonary vasodilators that you're familiar with, inhaled nitric oxide, inhaled prostacyclins. We'll list causes and treatments of pulmonary arterial hypertension, and most specifically there we'll talk about pulmonary embolism, which is a common cause of increased pulmonary vascular resistance. And then we'll finish off by talking about the west zones of pulmonary blood flow in the lungs and what are some of the implications of that as it relates to mechanical ventilation. So shown here is the pulmonary circulation as compared to the systemic circulation, making the point that pulmonary circulation is a low pressure and low resistance circuit. So the mean pressure in the pulmonary circulation is about 15 millimeters of mercury. It's about 100 millimeters of mercury in the systemic circulation, so that the mean pressure in the systemic circulation is about 6 times greater than in the pulmonary circulation. And that's related to the fact that the systemic circulation has to perfuse the head as well as the toe, the kidneys as well as the brain, whereas the pulmonary circulation only needs to move blood through the thorax. There's relatively little smooth muscle in the pulmonary artery, although there is some smooth muscle, which is the reason why pulmonary vasodilators can be effective. The reason why there's very little smooth muscle in the pulmonary artery is that the body does not need to distribute regional blood flow through the lungs the way that it distributes regional blood flow through the rest of the body. So there needs to be smooth muscle throughout the rest of the body so that, for example, when you exercise, you get more flow to skeletal muscle and so forth. So unlike any other vascular bed, the lungs receive all of the cardiac output, whereas there are regional differences in perfusion among other parts of the systemic or parts of the systemic circulation. So the pressures around pulmonary vessels in the lungs are determined by whether the vessel is surrounded by alveoli or alveolar vessels, or whether the vessel is not surrounded by alveoli, but is surrounded by the lung structure itself, or extraalveolar vessels. So alveolar versus extraalveolar vessels. The pulmonary capillaries here, the alveolar vessels, are surrounded by alveolar pressure. And the distension of the alveolar vessels, or the pulmonary capillaries, is determined by the difference between the pressure on the inside, the vascular pressure, and the pressure on the outside, the alveolar pressure. The distension of extraalveolar vessels is determined by lung volume, by radial traction. So in other words, as the volume of the lungs increases, that pulls out on the extra alveolar vessels and increases their diameter. And as lung volume decreases, there's less radial traction and the diameter of the extra alveolar vessels decreases. So back to the alveolar vessels or pulmonary capillaries, if there's an increase in alveolar pressure, that will cause the alveolar capillaries to collapse. So if we increase the pressure in the alveolus, such as with PEEP, that will have a collapsing effect on the pulmonary capillaries. On the other hand, if there's a decrease in vascular pressure, such as with hypovolemia, that will cause alveolar vessels to collapse. So we think then about our patients who we put on PEEP. If the patient is relatively hypovolemic and we put the patient on a lot of PEEP, that will tend to have a collapsing effect on the pulmonary capillaries and increase pulmonary vascular resistance, increase blood flow through the pulmonary circulation, or decrease blood flow through the pulmonary circulation, and then that can result in less left heart filling, systemic hypotension, and so forth. So this then brings us to a discussion of pulmonary vascular resistance. And the mathematical relationship here is similar to the relationship that we think about when we talk about resistance through the airways in the lungs. So the resistance through the pulmonary circulation is determined by the pressure drop across the circulation, so the entering pressure minus the downstream pressure, divided by the flow through the lungs. The flow through the lungs is cardiac output. So if we talk about measuring pulmonary blood flow, we're really talking about measuring cardiac output. The pressure drop across the pulmonary circulation is the difference between the mean pulmonary artery pressure, which we can measure with a pulmonary artery catheter, a picture of that on the next slide, minus the left atrial pressure. This is what can be measured with the Swan-Ganz catheter when measuring the wedge pressure. So this is the mean pulmonary artery pressure minus the wedge pressure divided by cardiac output. So normally the pulmonary artery pressure is 15 millimeters of mercury. Cardiac, the left atrial pressure is about 5 millimeters of mercury, or the wedge pressure is about 5. Cardiac output is about 5 liters per minute. So pulmonary vascular resistance then would be 15 minus 5, or 10, divided by 5, or 2 millimeters of mercury per liter per minute. So this then would be a normal pulmonary vascular resistance in what is called Wood units. So when you hear people talking about blood flow resistance in Wood units, it's millimeters of mercury per liter per minute. So again, relatively low pulmonary vascular resistance normally. So clinically, these things can be measured primarily with a pulmonary artery catheter. The central venous catheter that many of our critically ill patients have essentially just measures right atrial pressure. So it's just measuring the pressure entering into the left ventricle and into the pulmonary circulation. Whereas with the pulmonary artery pressure, with the catheter passed all the way into the pulmonary artery, one can measure with a port in the right atrium, the right atrial pressure. One can measure with the distal lumen of the catheter, the pulmonary artery pressure. And then when the balloon on the catheter is inflated and the catheter moves out into a wedge position, can measure left atrial pressure. So then if we want to measure the pulmonary vascular resistance, like this, we need a pulmonary artery catheter, so we can measure pulmonary artery pressure, and we can measure wedge pressure or left atrial pressure, and we can also, with the pulmonary artery catheter, as we'll talk about in a minute, measure blood flow or cardiac output, and we can get all of the components of pulmonary vascular resistance. So this is something that we used to do 20 years ago all the time in the ICU. So many of our mechanically ventilated patients and patients with ARDS had pulmonary artery catheters, and we used to calculate pulmonary vascular resistance quite commonly until it was shown that whether a patient had a pulmonary artery catheter or not didn't make any difference in their outcome. So now essentially the use of pulmonary artery catheters has pretty much gone away, except maybe in cardiac. So when he did the, or who was it who said, yeah. What happened to, there she is. So I think in cardiac you probably still see patients coming up with PA catheters.
Yeah.
So. And they're still used a fair amount in the cath lab when patients have cardiac caths. So then if we are going to assess, pulmonary vascular resistance, we need some measure of pulmonary blood flow. And since the lungs take all of the cardiac output, if we measure pulmonary blood flow, essentially we're measuring cardiac output. And in fact, the most common techniques that are used to measure cardiac output are actually measuring pulmonary blood flow. So then how can that be done? Well, the traditional, gold standard way of measuring pulmonary blood flow or cardiac output is through the use of the Fick equation. And the Fick equation says that the amount of blood flow, the pulmonary blood flow or the cardiac output, is equal to the oxygen consumption divided by the difference between the arterial oxygen content and the mixed venous oxygen content. So the gold standard way of measuring cardiac output from the Fick equation requires that we use indirect calorimetry to measure oxygen consumption, and we have an arterial blood sample so we can calculate the arterial oxygen content, and we have a mixed venous blood sample, which means that the blood is drawn from the pulmonary artery, the distal tip of the PA catheter, to determine mixed venous oxygen content. But the problem is that usually, clinically, we're not able to get oxygen consumption because we don't have an indirect calorimeter. And we're not able to get mixed venous oxygen content because most of our patients in the ICU don't have pulmonary artery catheters. But there are some ways that we can work around this a bit. So we can estimate the oxygen consumption from the carbon dioxide production. And we can get the carbon dioxide production relatively easily with the NICO device. So we can place a NICO, we can measure carbon dioxide production, and then if we divide that by the respiratory quotient, which is normally about 0.8, and only varies clinically from about 0.7 to 1, we can, by measuring carbon dioxide production with the NICO, get a reasonable estimate of the oxygen consumption. And even though most of our patients in the ICU don't have pulmonary artery catheters, and we can't get mixed venous oxygen content, most of our patients have a central venous catheter, so we can get a central venous oxygen content, which is not perfect as it relates to the mixed venous oxygen content, but it's probably close enough for clinical work. So then it is possible at the bedside to calculate cardiac output from the Fick equation by using a NICO to get CO2 production, drawing a mixed venous blood gas, and calculating oxygen content from the hemoglobin and mixed venous oxygen saturation, PO2 and so forth. And Patty will remember how much fun we had doing that up in the NICU a month or so before I hung it up and left. Or the other way we can get cardiac output, which used to be done very commonly in the ICU, and many of our patients on ventilators had pulmonary artery catheters, is through thermal dilution. So in the pulmonary artery catheter, there is a thermistor to measure temperature here near the tip of the catheter, and then a cold solution, usually room temperature cold, is injected into the right atrium. So by measuring how the temperature changes here in the pulmonary artery after a cold solution is injected into the right atrium, that temperature change is a function of the cardiac output and built into the device, which hooks onto the PA catheter, is all the computational software to figure out what the cardiac output would be based upon the temperature change here when a cold solution is injected here. Some PA catheters, and some of these were being used before I left, so I assume they're probably still being used, give a continuous cardiac output where there is a thermistor which is worn here in the pulmonary artery catheter, and the amount of cooling of that as the blood flows by the thermistor is used to determine cardiac output continuously. I know they were using them some up in the CCU, at least in the past. So then there are lots of things. So if we are able to measure pulmonary vascular resistance, what is the clinical implication of the numbers that we get? And as is shown on this slide, there are lots of things that can increase, decrease the pulmonary vascular resistance. So for example, the pulmonary vascular resistance can be increased with a loss of vascular bed. So if there are pulmonary capillaries that are wiped out, that increases the resistance to blood flow through the lungs, and that can occur with emphysema, COPD, with destruction of lung parenchyma, or that can be increased if part or all of the lung is reduced, is removed. So if one of the lungs is removed surgically, then that's going to increase the resistance to blood flow through the remaining lung. Positive pressure ventilation can increase pulmonary vascular resistance. We'll look at that in more detail in a minute. Hypoxia, or perhaps more specifically hypoxemia, can increase pulmonary vascular resistance. So that's hypoxic pulmonary vasoconstriction. We'll look at that in more detail in a few minutes. Vascular obstruction, like with pulmonary embolism, can increase pulmonary vascular resistance. And then there are patients who develop pulmonary arterial hypertension for an unknown cause, an unknown reason, which is called idiopathic pulmonary arterial hypertension. And those are the kinds of patients who are taken care of by the pulmonary hypertension pulmonologist and cardiologist. Pulmonary vascular resistance can decrease with decreased vascular tone, such as sepsis, with an increase in vascular pressure. So that seems at first paradoxical, that if we increase the pressure in the pulmonary circulation, that the resistance will decrease, but that's what happens, and I'll show you why in a minute. And then drugs can reduce pulmonary vascular resistance, so even though compared to the systemic circulation, there's less smooth muscle in the pulmonary circulation, there is smooth muscle that will respond to pulmonary vasodilators. And they can either be selective, meaning that they're inhaled, or non-selective, which means that they're administered systemically. And then lung volume might either increase or decrease the pulmonary vascular resistance depending upon what the lung volume is. So this illustrates the effect of vascular pressure on pulmonary vascular resistance. So here we're looking at pulmonary vascular resistance as a function of the pressure in either the arterial or the venous side of the pulmonary circulation. And as you can see, as the pressure increases in the pulmonary circulation, the resistance decreases. Decreases a lot with an increase in arterial pressure, pulmonary arterial pressure, and decreases, although not to the same extent, with an increase in pulmonary venous pressure. So then why is it that the greater the pressure is in the circulation, pulmonary circulation, the lower is the resistance? And there are actually two mechanisms for this. So one mechanism is that in you and I, normally, there are likely some pulmonary capillaries, illustrated here and here, that are collapsed. Then as we increase the pressure in the pulmonary circulation, that will cause those pulmonary capillaries to be recruited. So here there are pulmonary capillaries with no blood flow that now have blood flow as a result of the increase in pressure. So there's recruitment of pulmonary vascular bed with a higher pressure. And then also with a higher pressure, there is a distension or an increase in diameter of the already open pulmonary capillaries, which will also reduce the resistance to blood flow through the lungs. So interestingly, I think it's kind of paradoxical at first to understand that with an increase in the vascular pressure in the lungs, the pulmonary vascular resistance actually goes down. So then what about the role of vasodilators? So vasodilators will decrease the pulmonary vascular resistance, whether that vasodilator is administered systemically, intravenously for example, or whether it is administered by inhalation. In both cases, whether it is a systemic vasodilator, like nipride for example, or an inhaled vasodilator, like epoprostenol for example, there is a drop in pulmonary vascular resistance. So there's a relaxation of pulmonary vascular smooth muscle. However, there's a big difference in systemic vascular resistance, where with the systemic vasodilator, it's non-selective, it dilates the pulmonary vasculature, but it also dilates the systemic vascular, so systemic vascular resistance decreases, and the result of that is that the patient becomes hypotensive. Whereas with an inhaled vasodilator, unless there are very high doses of inhaled vasodilator, the effect on the systemic vascular resistance, the systemic circulation, and systemic blood pressure is much, much, much less. So that's then an advantage of providing an inhaled vasodilator, such as nitric oxide or prostacyclin, rather than a systemic vasodilator, like nipride or an IV prostacyclin, as far as that goes. Also, the inhaled vasodilator will dilate the blood flow past functioning alveoli, so that will reduce the shunt and increase the PO2, whereas the systemic vasodilator will dilate not only vessels going past open functioning alveoli, but also blood vessels in the lungs that are not flowing past functional alveoli. So with a systemic vasodilator, like nipride for example, it will make the shunt worse and the PO2 worse. And it's been known for many, 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 many years, 30, 40 years, that in patients with an increased shunt, like a patient with ARDS, if they receive a systemic vasodilator, like nipride, their oxygenation gets worse. And in fact, it's systemic vasodilators for that reason are kind of relatively contraindicated in conditions like ARDS, because it'll make the shunt and the PO2 worse. Whereas an inhaled vasodilator, as you all know, since you've all administered these to patients, it'll make the shunt better and the PO2 better, and the pulmonary vascular resistance better. So this is illustrated in this figure this is actually an article that a group of us published in Lancet earlier this year, a review paper, where we talk about selective pulmonary vasodilation as well as other things. And we had this really nice figure drawn for us, showing that if we administer an inhaled pulmonary vasodilator like nitric oxide or prostacyclin, that is going to selectively go to the ventilated parts of the lung. That'll increase blood flow past the ventilated parts of the lung, actually decrease then blood flow through the non-ventilated parts of the lung, and that results in an improvement in arterial PO2 and also an improvement in pulmonary vascular resistance. So then, the question is, well, what about? So the sort of the prototypical drug to do this has been inhaled nitric oxide. But as you know as well or better than me, this has now become inhaled prostacyclin. So what is the evidence to support physiologically the use of inhaled prostacyclin versus the use of inhaled nitric oxide? So this is a paper published about a year ago in Chest, which was a systematic review of the use of inhaled prostacyclins in patients with ARDS. And as you can see in this review, there are a lot of studies that are included. These, I should point out, are all observational studies. So they are not randomized controlled trials. They were not set up to determine if inhaled prostacyclins improve mortality and so forth. But in all of these, putting together all of these observational studies and looking at oxygenation, PO2 FiO2 ratio, there is a significant improvement here, a significant improvement in oxygenation with the use of an inhaled prostacyclin. So the evidence supports, at least in observational studies, that inhaled prostacyclins, Flolan, Velitri, that kind of drug, in patients with ARDS do improve oxygenation. Like nitric oxide improves oxygenation, selective pulmonary vasodilation. And in the same review, they showed, there are, a half dozen or so here studies that show that the use of inhaled prostacyclins in ARDS reduces pulmonary artery pressure. So it is a pulmonary vasodilator. Significantly lower pulmonary artery pressure with the use of inhaled prostacyclins. However, a couple of other important points about this is they also reported that hypotension occurs in about 17% of patients in these observational studies receiving inhaled prostacyclins for ARDS. So there is some spillover effect into the pulmonary circulation that causes downstream systemic vascular resistance and some drop in blood pressure. This, however, can be controlled to a large extent by the dose. So using lower doses results in less spillover into the circulation. But then the important, probably most important point is that outcome studies are lacking. So there are no studies that I'm aware of that have compared patients with ARDS who got inhaled Velitri or Flolan versus those who do not, and show that patients are more likely to survive if they get it. Those studies just haven't been done. So then the question that gets debated around the country, maybe not around MGH as much as it was a few years ago, but probably still is sometimes, is what should we use for ARDS, inhaled NO or prostacyclin? Well, certainly both are selective pulmonary vasodilators, and I don't think that's debated. Either can reduce pulmonary vascular resistance in patients with pulmonary hypertension. There's evidence to support that. Either can improve shunt and thus arterial PO2 in patients with ARDS. I just showed you some evidence for that for prostacyclin. Neither is FDA approved for inhalation in adults with ARDS. So NO is only approved for hypoxic term newborns. That's the FDA indication for inhaled NO. Prostacyclin is approved for systemic use, but it is not approved to be used by inhalation. So both of them are off-label uses. One has an approved delivery system, nitric oxide. The other one, we have a delivery system that works pretty well, but it's not really designed for that use. Neither has been shown to improve outcome. So inhaled nitric oxide has not been shown to improve outcomes in patients with ARDS, and prostacyclins haven't even been studied in that regard, to my knowledge. So then, what determines which one we use? Well, one is expensive, as you know, NO, and the other is relatively inexpensive, the prostacyclin. And the reason for using one over the other is not so much because the evidence shows that prostacyclin is better. Almost Bob knows of evidence that I don't know of. Not only the evidence shows that one's better than the other, but one is significantly less expensive. And neither of them have been shown to improve outcomes. So we don't have any evidence that in a patient with ARDS who we put on inhaled Velitri, that the patient will be more likely to survive. Those studies haven't been done.
The other comment I would just make is that there are some patients that will respond better to one or the other. For what reason, nobody knows for sure.
Yeah, so
some patients do nitric, some patients is prostacyclin.
So I didn't put that in. I actually debated whether I was going to put slides in about that. So the pharmacologic pathways are different. So NO works on a different pathway than prostacyclins. And then there are actually 3 pathways of drugs for patients with increased pulmonary vascular resistance. So some affect the nitric oxide pathway, some affect the prostacyclin pathway, some affect the endothelial receptor pathway. So I think that's probably the reason.
Yeah, and one receptor group may be more sensitive to another compared to another in a given patient. You just don't know. So when one fails, that's why they want to go to the other one, because the other one may work much better, even though, you know, nitric oxide initially didn't. And prostacyclin may work well.
Yeah, and the other thing is that's also true for idiopathic pulmonary arterial hypertension, and some of you may have seen patients that probably still were when I was around a lot, that get admitted to the MICU and they put in a pulmonary artery catheter, and then they trial patients on different types of drugs to see which one they need. So then what about the effect of lung volume on overall pulmonary vascular resistance? So we talked a little bit about the effect of lung volume on pulmonary capillaries versus extraalveolar vessels. And it turns out that the relationship between pulmonary vascular resistance and lung volume is kind of this U-shaped relationship. So at low lung volumes, pulmonary vascular resistance increases, and it likely increases because there's a loss of that radial traction on the extraalveolar vessels. So here's the diameter of the extraalveolar vessel. This lung volume, we go down to this lung volume, the diameter of the extraalveolar vessels decreases, and that increases resistance. However, if we increase lung volume, then we squash the pulmonary capillaries. So here, the capillary compared to here, with the higher lung volume, it affects the transmural pressure so that there's an increase in resistance through the extraalveolar vessels. So for the blood to get from the right side of the heart to the left side of the heart, it has to flow through the extraalveolar vessels as well as the pulmonary capillaries. So the pulmonary capillary effect predominates here, and the extraalveolar vessel effect predominates here. Turns out that the pulmonary vascular resistance is the lowest at about where the FRC normally would be. Well, that would make sense, that we would have evolved to the point where pulmonary vascular resistance would be at about the lung volume where all of us are breathing right now. So what implications might this have for our patient on the ventilator, say our patient with ARDS? So what does ARDS do to lung volume? Reduces lung volume. So it shifts us down here. And then what does that do to pulmonary vascular resistance? Lung volume goes down, pulmonary vascular resistance goes up. When the pulmonary vascular resistance goes up, the patient is more hemodynamically unstable. Now what do we do for the lung volume? We put the patient on PEEP. So we put the patient on PEEP, we increase the lung volume, and initially we should see that the patient's hemodynamics get better. Pulmonary vascular resistance goes down, more blood flow to the left side of the heart, better cardiac output, better blood pressure. Well then, what happens if we add too much PEEP and we drive the lung volume up here? Now what will happen is the pulmonary vascular resistance will go up. As the pulmonary vascular resistance goes up, less blood flow from the right side of the heart to the left side of the heart, less left heart filling, less cardiac output, less blood pressure. So then the sweet spot here should be somewhere around a normal FRC. So the use of PEEP then might make hemodynamics better, might make hemodynamics worse, in part because of where we are, where our patient is with this relationship. And then what about the effect of positive pressure on vascular resistance? So let's imagine here that we have two alveoli, one which is being ventilated, one which is not. Alveolus represents a shunt, So this may be an alveolus that is consolidated, say with pneumonia. And then what happens if we come along and we put on too much PEEP? Well, if we put on too much PEEP, that overdistends this alveolus. If we overdistend this alveolus, it increases the regional resistance to blood flow past this alveolus. If the cardiac output stays the same, then we get more blood flow going to the shunted alveolus, and the patient's shunt can get worse, oxygenation can get worse, and dead space can get worse. Which is why sometimes when we do our PEEP titrations, when we overshoot with PEEP, the patient's sats drop because of alveolar overdistension, increasing resistance to blood flow, compression of pulmonary capillaries. Now, another thing that can increase pulmonary vascular resistance is a decrease in PO2, a decrease in alveolar PO2, and a decrease in the PO2 in the pulmonary vascular bed. And this is commonly called hypoxic pulmonary vasoconstriction, or HPV. So what happens here, as you can see on this relationship, if the alveolar PO2 goes down, that reduces the blood flow past a lung unit. So there's vasoconstriction that occurs as a result of hypoxemia. Now, normally this is a good thing. So usually this is protective. So if I get a right lower lobe pneumonia and my right lower lobe becomes consolidated, there will be a lower PO2 in the right lower lobe. That will cause pulmonary vasoconstriction in that part of the lung and redistribute blood flow to the rest of the working lungs so that the PO2 may not change very much. So a patient can have a significant consolidated pneumonia, for example, and the PO2 may drop from 85 to 65, but you might expect it would drop a lot more if there was not the protective effect of hypoxic pulmonary vasoconstriction. But the problem becomes, this becomes maladaptive if there's generalized hypoxemia. Because with generalized hypoxemia, such as in a patient with COPD, right, Nancy, correct me if I make a mistake here, if there's generalized hypoxemia, then that will increase pulmonary vascular resistance, and in COPD, usually pulmonary vascular resistance is increased, actually for two reasons. Because of loss of pulmonary vascular bed, destruction of pulmonary parenchyma, and also because of hypoxemia. Then this results in an increase in right ventricular afterload, and that can result in cor pulmonale, which we'll talk more about in a minute. That can result in reduced left heart filling, reduced cardiac output, and so forth. And then if we administer oxygen to that patient, a COPD patient with generalized hypoxemia, that should decrease the patient's pulmonary vascular resistance. That should improve the patient's hemodynamics, and in fact, sometimes these patients, when they get started on oxygen, they will have a diuresis as a result of that and so forth because of the positive effects of hemodynamics. And where that is used, and Nancy's actually the expert in the room on this, where this effect is used primarily is in patients, hypoxemic patients with COPD and pulmonary arterial hypertension. So then, what are some of the things that can drive up the pulmonary artery pressure, which is pulmonary arterial hypertension, and by definition, the accepted definition in the literature of pulmonary arterial hypertension is a mean resting pulmonary artery pressure of greater than or equal to 25 millimeters of mercury. Remember, we said way back at the beginning that normal is 15. So the pulmonary arterial hypertension can be the result of pulmonary arterial disease, and there are a lot of things here on the list. It can be the result of left heart failure because of blood backing up into the pulmonary vasculature. It can be the result of lung diseases and hypoxemia, so COPD, ARDS, pulmonary fibrosis, sleep disordered breathing result in pulmonary arterial hypertension. It can be the result of thrombotic or embolotic disease, pulmonary embolism primarily, and we'll talk more about that in a minute. and then other sort of more rare things that can cause pulmonary arterial hypertension. So a lot of things then can cause pulmonary arterial hypertension. So perhaps it should not be surprising that we see patients as often as we do who have high pulmonary artery pressures. So pulmonary arterial hypertension, PAH, there's vasoconstriction and vascular remodeling in the precapillary segments of the pulmonary vasculature. Many times, pulmonary arterial hypertension is idiopathic, so the cause is unknown. And in fact, by far, the most common reason that patients develop pulmonary arterial hypertension is idiopathic. Then as the right ventricular afterload increases because of the high pulmonary artery pressure, there's worsening, there's right ventricular hypertrophy, dilation, and right ventricular failure, which then can lead to left ventricular failure. And if the right heart failure is caused primarily by a disorder of the respiratory system, that's called cor pulmonale. So the high pulmonary artery pressures that occur in patients with COPD, for example, is called cor pulmonale. And COPD and idiopathic pulmonary fibrosis are the most commonly associated with that. So then what drugs are out there that are used to treat pulmonary arterial hypertension? So this kind of gets back to what we were talking about before. So there are drugs that are prostacyclin analogs, there are endothelin receptor antagonists, and phosphodiesterase 5 inhibitors. So the prostacyclin analogs are things like ibuprostanol, so that's Flolan, Velitri, which is usually administered intravenously, can be administered by inhalation. You do that all the time, but it's not FDA approved for inhalation. Iloprost, which is approved for inhalation. In fact, that is the way that it is administered most commonly. And treprostinil, or Tyvaso, which can be given subcutaneously, intravenously, or by the inhaled route. And we'll look at the delivery devices for these, I think, on the next slide. As far as the endothelin receptor antagonist, bosantin is the most common one that is used. And the phosphodiesterase 5 inhibitors, this is Viagra and Cialis, which are very commonly used for pulmonary hypertension. So iloprost and treprostinil, can be administered by inhalation. And in fact, the way of administering iloprost is by inhalation. And some of you may be familiar with this device because we have patients who come in from time to time who bring this device with them from home. So iloprost is Ventavis, prostacyclin. It uses a specialized inhalation device, which is called the iNeb adaptive aerosol delivery device. And the way that it works is really, I think, kind of clever. So the patient puts the mouthpiece in their mouth, and the patient begins breathing in and out through the device, and the device learns the patient's breathing pattern. So it learns how the patient's breathing. And then once it identifies how the patient is breathing, it injects the dose at the very beginning of inhalation. So why is that important? Well, the gas at the very beginning of inhalation is the gas that's going to make it to the alveolar space. Whereas you wouldn't want to inject at the end of inhalation because then the gas would just go into the dead space. So it's very clever in how it maximizes the potential that the drug will reach the part of the lungs where it's going to be effective. And then treprostinil is Tyvaso. So this is administered 6 to 9 times a day, so frequent administrations. This is 4 times a day, 3 inhalations per session. And this, at least in my opinion, uses a much more clumsy device. So this is an ultrasonic nebulizer, it has filters, it is not nearly as friendly to use as the iNeb device.
Have we seen any patients here on Tyvaso? Anybody?
Tyvaso?
Yeah.
Okay. I've seen them on iloprost, but I've never seen a patient.
So I was told at one time that this was a an increasingly favored drug, Rich Jennings. And, and in fact, when I was pulling up some articles to prepare this talk, I actually did prepare the talk. When I looked up Tyvaso, the first article that came up was a review of Rich Jennings had written. So I'd be surprised if we're not seeing patients that are coming in with it. Amy, you've seen patients?
One time, yeah, he was actually being sent home on it, but the home care company brought the device in and, yeah, we set it up. There's a lot of components to it.
Yeah, there are a lot of pieces. There are, yeah, a lot of pieces.
But it was Dr. Channing's patient.
Yeah. Okay, so then a couple of slides on pulmonary embolism, because pulmonary embolism is a common cause of increased pulmonary vascular resistance in patients who we may see in the ICU. And in fact, of critically ill patients, pulmonary embolism has been reported in as many as 25% of postmortem examinations. So that's 1 out of 4 critically ill patients, and it is thought to have caused or contributed to death in as many as 1 in 10. So that's a lot of patients who are affected by pulmonary embolism. Here is the important thing. Clinical suspicion of pulmonary embolism only occurred in less than a third of these patients. So it usually is missed. So a place where we could perhaps make a difference is in that patient who's not ventilating well, not oxygenating well, has a fairly clear chest x-ray, unclear what's going on. Maybe it's worth mentioning perhaps pulmonary embolism. Now, I'm sure you think that they consider pulmonary embolism on everybody because they all go for CTs, as we'll see on the next slide. Venous thromboembolism, VTE, includes both deep venous, DVT, and pulmonary embolism. About 90% of the cases originate in deep venous circulation of the lower limbs, and acute PE results in increased pulmonary vascular resistance, increased right ventricular afterload, decreased left heart filling, hypotension, and so forth. So there are a number of ICU and non-ICU factors that can increase the risk of pulmonary embolism. So just being on a ventilator, probably because of the immobility, results in an increased risk of pulmonary embolism. Femoral venous catheters, this is the reason why femoral venous catheters are usually avoided. Sedation, paralysis, vasopressors, platelet infusion, sepsis, and so forth. So as you can see, this actually fits many of our mechanically ventilated patients. Non-ICU risk factors are persons who are more elderly, have a history of VTE, obesity, which we see increasingly in critically ill patients, lots of medical comorbidities, and so forth. So this is a very common thing. So it's actually surprising that it's missed as often as it is, or as common as it is known to be. So as far as diagnosis of pulmonary embolism, clinical features are non-specific and are often not very helpful. So the things that are in the textbooks, like pleuritic chest pain and tachypnea and hypoxemia, which are going to put on the slide and so forth, can occur with lots of different causes of lung disease. VQ scanning, which is used sometimes on outpatients, is not practical in the intensive care unit and mechanically ventilated patients. We probably have, mechanically ventilated patients probably have 1 every 5 years maybe that goes for VQ, because everybody knows it's all very rare anymore. I know it used to be a big deal every time somebody had to go down because you had to put on the scavenger and so forth. So the way that these are diagnosed, and kind of what's becoming sort of the gold standard for diagnosis, is spiral CT pulmonary angiography. So, so I'm sure that you probably think that everybody gets worked up for a PE because of all the CT runs that you make. Pulmonary angiography used to be the gold standard. It's rarely indicated anymore because CT angiography has gotten so good. In the diagnosis of PE, D-dimers are often mentioned. They tend not to be very specific. However, if a patient has a negative D-dimer, it's unlikely that they have PE or thromboembolic disease. And the treatments, as you know, are anticoagulation, thrombolytic therapy, IVC filters. This is becoming actually very controversial as to whether they should get put in, how long they should be kept in, whether you should use a specialized type so they can be taken out eventually. It's become, interestingly, more controversial than I appreciated. And then for massive PE, surgical embolectomy. So, final thing we're going to talk a little bit about is the distribution of blood flow throughout the lungs. So I guess not surprisingly, if you inject yourself or a patient or another person with a radioactive isotope, and then you look at where that radioactive isotope ends up in the lungs, there is more of it at the bottom of the lungs than there is at the top of the lungs. That's just the gravity effect. So most of the blood flow is to the bottom of the lung, and it's important that we think about it as the bottom versus the top and not the base versus the apex, because this will be affected by position changes. So we think about our patient who is on their side, a patient who is prone, that will affect blood flow through the lungs, because this is not a base versus apex effect, but a bottom versus top effect. So now something that was introduced very, very many years ago by a very prominent respiratory physiologist, John West, who is still alive actually, is what is called the West zones of pulmonary blood flow through the lungs. And what this says is that towards the top of the lungs, in the upright individual, towards the apex, blood flow through the lungs is determined primarily by the difference between alveolar pressure and pulmonary artery pressure. And if the alveolar pressure increases, that will tend to cause contraction, collapse of the pulmonary vasculature. So here in zone 1, blood flow is manipulated primarily by what happens in the pulmonary capillaries, determined by alveolar pressure and pulmonary arterial pressure. Whereas in zone 2, in sort of the midpoint of the lung, the flow is determined by the difference between pulmonary artery pressure and alveolar pressure. So the vessels are not collapsed, but the diameter of the vessels is determined by how large is the arterial pressure versus the pulmonary alveolar pressure. And then in zone 3, and this is sort of drawn like these are equal areas. Normally, zone 3 probably comes up to about here, and then we have some zone 2, and there's very little zone 1. Because if you think about this, is dead space. And most of us have very little dead space. In zone 3, which is most of the blood flow through the lungs, the flow is determined by the difference between the pulmonary arterial and the pulmonary venous pressure. And throughout most of the lungs, normally the alveolar pressure is relatively unimportant unless we do something to our patient clinically to drive up the alveolar pressure, like with PEEP and positive pressure ventilation and so forth. So zone 1 is dead space. And that's increased with positive pressure ventilation and hypovolemia. And normally, for you and me, we have very little zone 1, which is why I say this should probably be drawn as zone 3, goes from here to here, a little bit of zone 2, and very little zone 1. And then zone 3 is increased with volume loading. So if a patient is hypovolemic and then gets a fluid challenge, that will increase the pulmonary arterial pressure, and that will increase the amount of zone 3. Okay, I wasn't sure I was going to get through this in an hour, but I guess I did. So the pulmonary circulation is normally a low pressure, low resistance circulation. Pulmonary vascular resistance is calculated from the pulmonary artery pressure, the left atrial pressure, and cardiac output. So if we want to measure, give a number to pulmonary vascular resistance, our patient needs to have a pulmonary artery catheter. There are a number of pathophysiologic factors and medications that can increase or decrease pulmonary vascular resistance. We spend some time talking about that. And the distribution of blood flow in the lungs is determined by the pulmonary arterial pressure, pulmonary venous pressure, and alveolar pressure, and that was the lesson that we just looked at. So, then, where does this leave us? Well, we talked about ventilation, we talked about diffusion, today we talked about blood flow. I think Ed has recorded these first two, so if you weren't here for the first two, and you want to see the whole series, you can look at them. Is that available?
The first one's on, the second one will be on soon.
Okay, so on in RC Share?
And no, it's in Health
HealthStream, yeah, right, okay.
Yeah.
So then next time, we will talk about gas exchange. So this will be the physiology of what affects blood gases, primarily oxygenation. So we'll talk about shunt and DQ and some of those fun things, at least fun things for me. Okay, questions? Yes, Kevin.
Dean, very good job, thank you. Quick question about, you mentioned the effect of PEEP on pulmonary vasculature resistance, and we all know well the effect of PEEP on oxygenation and compliance, and that's what we focus on when we do like a best PEEP study, recruitment maneuver. Is there a disconnect between the two, or is it the same sweet spot? Would a best PEEP in terms of pulmonary vasculature be the same best PEEP in terms of, what I'm getting at, would it be an alternative way to calculate a best PEEP? But if they're disconnected, it probably wouldn't be.
So years ago, and you probably remember this, when we did PEEP studies, our patients almost always had PA catheters, and we would look at cardiac output when we did the different levels of PEEP, and we looked at PA pressures and so forth. And the sweet spot, I think, is probably very close for all of those things. So I don't think you should take away from this lecture that you need to measure lung volume or pulmonary vascular resistance to know where to set the PEEP. If we overdo it with the PEEP, then that will drive up pulmonary vascular resistance. That will decrease left heart filling. That will decrease cardiac output. That will, as I showed in one of the slides, if we over-distend regionally some alveoli, that'll make the shunt worse, and the PO2 will go down. The other reason why the oxygen saturation of PO2 may go down is when you increase the PEEP and you cause adverse hemodynamic effects, increase PVR and so forth, is that then results in a lower mixed venous oxygenation, which we'll talk about in one of these lectures. And so we reduce the mixed venous oxygen saturation, we have a big, that'll drop the arterial saturation as well. But my guess is that probably the sweet spots are similar. So we know, when we did the lecture on ventilation, we looked at how PEEP can increase dead space because of the zone 1 effect. Bob's dying to say something.
So, I mean, just look at all the data we've accumulated in the obese patients where we're using compliance. Essentially, we're seeing no significant negative effect on pulmonary vascular resistance. We're going to be looking, going forward, doing significant assessment using ultrasound before, during, and then long-term afterwards. And we expect that there will be no negative and potentially a positive effect because you get to that sweet spot of the real FRC.
As long as you don't overdo it.
As long as you don't overdo it. But if you use compliance, as Dean said, and you're trying to match FRC, you should not see a significant problem, provided the patient is, fluid, neutral.
So we can assume that our best PEEP is beneficial in terms of the vasculature as well.
Again, assuming vascular volume is okay, that should be the case, or that the patient has no significant cardiac problems. Now, if somebody's got significant cardiac problems, maybe not, but if they're reasonably stable cardiac-wise and got good vascular volume, they should be okay.
Yeah, I mean, I illustrated the effect of hypovolemia, which is also to reduce the diameter of the pulmonary capillary and increase PVR.
Right.
Yes, Sid.
What's the cost of Voletri for the day versus Nitro for the day?
About a 20 to 1 difference.
20 to 1?
Yep.
Okay.
Velitri, Dan, help me here. Velitri, I think, costs $100.
$200 a day for nitric.
Right.
200, okay.
It's $150 an hour for nitric.
Right, I used to
50
say,
per hour?
when I would be asked this question,
So figure it out, it's about a 20 to 1.
Wow.
yeah, when I was asked this,
It was
when
pricey.
I get asked this question, my typical response is that 1 hour of nitric costs about the same as 1 day of
Wow,
Velitri.
yeah.
Right.